So I'm going to be talking quite a lot about electronic health records during the course of the talk, and most of it will be negative. So I'm going to start out with a confession. I like the electronic health record that my GP uses. I think it's very useful. I think that electronic health records are going to bring lots of utility in the future, and all of the negative things I say should not be taken to imply that I think we should abolish electronic health records, just to make that clear. People think that electronic health record technology or medical IT generally is going to save a lot of money. So in 2005, David Brailer talked about saving $77 billion a year because we will avoid duplication in tests and so forth as a result of the fact that we can all share data because we have these nice electronic health records. Now, I think that that is not just an exaggeration. I think it's almost 180 degrees false. So I think, in fact, the investments being made in electronic health records are costing money rather than saving money. Now, that may change. We will see what would be involved in bringing about a change of that sort as we go on. In 2012, a Time magazine correspondent viewed the health IT component of the ARRA Act as being a no-brainer. Indeed, it may be the most lasting bipartisan and transformative piece of the stimulus bill. We should just accept it. It's wonderful. It's good. It will only bring positive benefits. This is the assumption. And indeed, it does bring positive benefits. So we can indeed reduce gaps and duplications and prescribing errors. The issue is whether we can do this, whether we can use health IT and EHR technology to make needed clinical information accessible to all appropriate providers in a more complete and timely fashion than paper records. Now, this seems like a no-brainer. It seems obvious that it would be better to have patient records inside computers rather than on pieces of paper which may be stored in separate buildings, so that you can have all the relevant data on your computer screen instantaneously before you order a new test. This seems obvious. So, again, David Brailer. Currently, as soon as a patient arrives at a hospital, a battery of tests is performed because clinicians have no way of knowing what has already been done. Eliminating this inefficiency through interoperability, that means all the computers have to talk to each other. That's the key. Is a significant challenge. We will see that he is right about that. But it does not, he says, require magical changes in the business processes or culture of healthcare to be realized. I think he's completely wrong about that. So what he says is it's just about obtaining data by calling it up on a computer system rather than waiting for pieces of paper to be found and collected and delivered. Now, this is not easy. So, Brailer's idea is that this is a no-brainer. We need to get all the information into the computer. Eventually, all the problems which arise once the information is in the computer will be solved by the market. Companies will come in and they will tell us how to do this, and they will provide super-duper tools which will make it easy to do it. But for the moment, there is a problem, and we are just past the point where that problem was probably at its peak. Because we already have lots of people who are using electronic health records, probably lots of people in this room. But at the time when Brailer was writing, which was 2005, having an electronic health record system was like having a fax machine when no one else had a fax machine. And so your fax machine was practically useless for all of these benefits because most of the data was still on paper. The early adopters of electronic health record technology had another problem. There were, at that time, roughly 300 different EHR products, and hospitals and providers did not know which product to buy. They didn't have any idea of what the benefits and costs would be in the form of retraining, re-engineering, and so forth. And the costs were not clear. So the cost of this product itself may be just a few $100,000. But then the costs of making the changes which turn out to be needed 6 months later may be another few $100,000. Now, physicians at that time did not know how to deal with these problems. They had no idea what was going to happen. Now we have a clearer idea. Moreover, the vendors of electronic health records had an interest in keeping things unclear, and they had an interest in preventing interoperability. So the harder it is to use their systems in a way, and the less fitted they are to the contexts where they would be used, the more money the vendors of the systems could make. Moreover, unless we have interoperability, because patients move from one hospital to another or from one provider to another, and because there are so many different systems, it's likely that the data will not move. So if you're a provider, you have a patient who has had 17 different tests at 4 different institutions, it may be that your computer cannot find information about any of those tests. Some of the information is still only on paper, and some of it is in systems which are maintained in different hospitals. Some of it is in different systems which you couldn't read the data from anyway. And some of it is in the same systems, but you can't read that data either for one of a number of reasons. Even if you're in the same building using the same system, it's not necessarily the case that you'll be coding in the same way, because the systems themselves allow all kinds of flexibility in order to make it possible for people in different hospital contexts to code just the information that they need in just the way that they need to code it. The more you give people the freedom to code as they need, the less you promote interoperability. So, interoperability standards exist. The government wants you to conform to these interoperability standards. But I see I wrote down slapdash. I think it's a lot worse than slapdash, but we'll come back to that. So I have a blog. So the one blog I have in my life is called HL7 Watch. What I'm saying now is being taped, and so I will not tell you what I think about HL7. But it is a standard for interoperability. So remember, we have the costs to early adopters. Electronic health record technology is hard to implement, and it doesn't bring all the benefits that are promised, and it brings further costs down the road. David Brailer and his successors realized that there were these costs for early adopters, so they thought they would solve the problem by encouraging people with incentives, and then by penalizing people with penalties if they fail to adopt electronic health record technology according to a timetable which the government laid down, because this is a no-brainer. Let's have more of it. Nothing can go wrong. So let's pay people to get more of it. And so $27 billion in incentive payments for people who adopt electronic health record technology. And the payments are scaled so that gradually you're running out of your chances to get some of this money. Now, there are some questions which arise immediately. So why do it so quickly? It's hard to do. The very few people are trained to do it. No one knows what the consequences will be. Some of them we already know now are negative. The systems themselves, to be honest, and I will say this even though it's being taped, are bad. They're 30 years old. They do not use the best current technology. And there are too many of them. And they're not interoperable because the vendors don't want them to be interoperable. The one bright star on the horizon is the Veterans Administration system, which is interoperable with itself. That's sort of trivial. Lots of people use it. It's free, except for the costs of installing it, training people, and so forth. I believe that there was a lot of magical thinking going on in around 2005 when these ideas were being created and when they were then made law. Magical thinking that you could solve these very, very difficult problems just by giving money to people to solve them quickly. Now, another reason why electronic health record technology was defended was that it would solve problems of confidentiality and security of information. So paper data can be read. You can see it on people's tables, or you can steal it from the rooms, which at that stage, I presume, were usually not locked, where the data, or were often not locked, where the data is kept. But data in computers, people thought, is much more secure. People are laughing. So I don't need to go on to that. We've seen this already. So by now we should see the idea that it's about obtaining data by calling it up on a computer system rather than waiting for medical records to be delivered. This is magical thinking. We still don't know how to do that. Now, another problem, this problem was recognized already earlier in Europe, because in European countries, they went through this process in the 90s. They had some advantages because they were largely single-payer systems, and so they could impose interoperability in the same way that the VA imposes interoperability on all its hospitals. And they too wanted to do this quickly, and so they too had incentive systems paid to doctors for installing electronic health record technology. And there was a very interesting scam which was used. A software company would come along and create a piece of software, toy software, called super duper electronic health record software. And it would cost $50 to create. And it would enable you to enter data, and that's it. You couldn't do anything with it. Maybe you couldn't even enter data. You could just install the thing on your computer and then get a receipt from the software company that you'd paid for the installation. And then the provider and the software company would split the incentive funds. So if the incentive funds were $20,000, cost $50 to install the software, then they split the $19,950 between themselves, and everyone was happy. Lots more electronic health record technology and lots more money for software companies and also money for doctors. Now, in order to prevent this problem, in order to thwart this scam, the European governments invented something called meaningful use. Meaningful use is a requirement that electronic health records software should actually be useful. And of course, then you have to define what useful means. And that process is the process that we're currently living through in the US. And it's a staged process. And the stages go hand in hand with the incentives and the penalties. So stage one, these dates have been pushed back somewhat. Stage one is the stage where the goal is just to capture information. Stage two is the goal of being able to report information outwards so that it can be useful, for instance, in quality measurements. And then stage three is levering this information to improve outcomes. And this is the key to one economically important pillar of Obamacare, that by having ever more and ever better patient data, we will be able to identify ways in which we can save money and improve care at the same time. Now, stage one capturing health information in a coded format, using the information to track key clinical conditions, communicating captured information for care coordination purposes. I think that number 3 is where it begins to go wrong, precisely because of this failure of interoperability. And number 4, so numbers 1, 2, and 4 here, I think are already being achieved. So I think that there is some genuine use to the meaningfully used electronic health record data that we have. The question is whether this will continue in the ways required. And each of these objectives has a measure of success attached to it. So in order to get the money, you have to, for instance, maintain an active medication allergy list, and 80% of your patients have to have such an allergy list in the electronic health record for that patient, and so on. Now, there is quite a literature in the meantime on the ethical dimensions of meaningful use. So the idea is that the quality and safety benefits from electronic health record technology, which is being developed to satisfy these rules, could be so substantial, he says, that non-attainment may be egregious. So in other words, we were behaving unethically if we failed to meet the stage thresholds in a timely manner. And this would, he says, confer an air of third world competency. So I find this statement absolutely amazing in the ignorance of the author of this statement, how difficult the problems are to make electronic health record technology work in the ways described. With regard to stage 1, you can see how it might work, but with regard to stages 2 and 3, as we shall see, no one knows how to make it work, except the VA. The VA is making some of it work, but the VA has a very special set of circumstances. This is another paper. The need to bring clinical charting traditions into the electronic format is obvious. Anyone who works in a clinical setting knows that retrieving information from an outdated or otherwise separate chart is burdensome and inefficient. Having that information in a structured, easily retrievable format is a great boon to both healthcare professionals and patients. Now again, we can get that information in one system. We can even get it in a form that the patient can read it. I have this already with my own GP. The problem is that most patients have several bodies of electronic health record information in several systems. And to get those may be even harder than to get paper documents. At least paper documents you can read. You can only read the data in other systems if you have the rights and the training in those other systems, which a given provider probably won't have. Now, again, the government is trying to solve these problems, as we shall see, but the problems are really very difficult. Last week, there was a congressional hearing on interoperability. So the Subcommittee on Technology and Innovation of the House of Representatives had hearings on meaningful use. Is meaningful use delivering meaningful results? And they had 4 magical thinkers, all of whom said, of course, there are no problems. The VA is doing wonderful things. So this lady, Willa talks about the impactfulness of electronic health record systems adoption is highly dependent upon health information exchange. And then she talks about health information exchange, how there's already state investment in health information exchange infrastructure and so forth. And there is a lot of investment. But then if you go to the places where health information exchanges are described, you find out there's only one. It's the VA. There are no other health information exchanges. There is money being paid to think through the problems of health information exchanges, but there is only one working exchange. There is something called the virtual lifetime electronic record. As far as I know, maybe that I'm wrong here, but as far as I know, although this is to be the core of the nationwide health information network exchange, so the big nationwide one, virtual lifetime electronic record. As far as I can tell, it's only the VA that's got one of those things. Now, it may be that the military has it too. That's not clear from the websites where this information is provided. But it's pretty clear that no one else has managed to do it, for the reasons I've explained. Lifetime electronic health records will almost certainly be in multiple systems. Now, stage 2. We're going to use electronic health records for clinical decision support. For 30 years, people have been trying to do that. Some people are doing it in small ways, but the idea that you should have a national program, which by around 2013 would have solved all the problems of clinical decision support, is magical thinking. Now, medication management, perhaps we can do that. That does not necessarily involve lots of difficult informatics issues in its resolution. It's a database issue, and it's usually related to relatively short segments of patients' lifetimes, and so you have a good chance that you'll just have one electronic health record to deal with. Support for patient access, we already have that, so, or I have it, I guess many of you have it. Transitions in care are going to be difficult for the reasons explained, because they will typically involve move to another hospital. Quality measurement, I'm skeptical. Research, I'm mixed, so I talk about that at the end if there's time. Bidirectional communication with public health agencies. Well, we've got that within the VA already, and perhaps between the VA and the military. But that's not the sad part. I'm quite happy. This is the sad part. This is the final rule for the stage 2 standards, which is 130 pages with small type. So all the pages are, if you print it in normal type, it's 470 pages. And the pages look like this. So in the proposed rule, based on our proposal to codify all the 2014 edition EHR certification criteria in paragraph 170.314, we clarified that certification to the certification criteria at paragraph 170.314 would occur at the second paragraph level of the regulatory section. It's all like that. Now, I am a big fan, as many of you know, of HL7. And HL7 often claims that HL7 use is required according to the meaningful use legislation. So I tried to check, and other people tried to check. HL7 is indeed mentioned in this document, but no one could find out whether it's required. No one can read the document in such a way that that simple question gets a clear answer. And I invite you to read it. So the link is here. So what can go wrong? This is supposed to promote interoperability. Now, there is a dark literature on the ethics of health IT, which I invite you to explore. So this gentleman here believes that when EHRs are introduced into emergency rooms, there is a 20 to 30% decrease in efficiency, which is primarily caused by the fact that people are distracted from what they should be doing in emergency rooms. Now, this could be causing death. It's certainly causing longer queues in emergency rooms. Now, another problem, which I don't have time to go into here, although I imagine that you're all familiar with it, more familiar with it than I am, that the requirements built into the HITECH regulations on security and privacy of patient data are causing delays also. And so this gentleman who's familiar with these problems says that that they are complex, costly, and poorly understood by the majority of providers. So while it may be true that computers can have better security procedures than paper, those security procedures involve very, very sophisticated strategies, and also very clumsy strategies, like people having to renew their password every week or however often it might be. And you don't always remember your password or passwords. So now people are talking about health IT related deaths. So the Institute of Medicine is called EHRs, electronically hospital caused disease. So this is the Institute of Medicine. I'm not making this up. Now, we do not understand iatrogenesis yet. But there is an undergrowth of iatrogenesis web content, which I invite you to explore. Things are going wrong. Now, I'm nearly at the end. There have been a series of disasters, and I'm not now talking about IT-related deaths. I'm talking about huge investments in national IT systems or in statewide IT systems, which failed and which just cost huge amounts of money and which probably set the positive features of IT technology back in the relevant places because people were burned. People saw that there were hugely expensive and hugely positively touted programs to introduce health IT quickly, which failed. Now, some of these are in Scandinavia. So people say that Scandinavia is the place where the successes of health IT is demonstrated. So I didn't bring the details about the Scandinavian disasters here, but if you look up Stockholm and health IT disaster in Google, you'll find some details. And I'm not going to mention any role of HL7 in that particular disaster. Another disaster took place in Victoria, Australia. And I'll just read you from the relevant newspaper article. This is relatively recent. The state government is considering abandoning Victoria's trouble-plagued $360 million health technology program. That's very cheap by disaster standards. It's called the Health Smart program, and it's 5 years late and $35 million over budget. Is supposed to link computer systems in hospitals and introduce processes such as electronic prescribing. But they only got it partially running in 4 hospitals, and doctors say patient safety is compromised by inadequate procedures that causes them to duplicate test results, and compete for access to computer terminals. That's just in the 4 hospitals where they got it partially working. But there is another disaster in Santa Barbara, which is interesting in similar sorts of ways. Again, you can Google that. But the really interesting one, the really big one, is in the United Kingdom. It was called the National Program for Health IT. And some of the planning for the Obamacare IT is based on what happened in the UK. So the idea was that all the electronic health records in the whole country would, all the health records, so that means that they would all be electronic, all of them, paper would cease to be used, would be collected together in one building in Middlesex. And if anybody in any hospital in the country, or I believe any provider in the country needed to have patient data, they had to dial in or be connected to this building in Middlesex. They never got to that point, but that was the idea. The building would be open 24 hours a day, 7 days a week, so that's good. And the building would enable people to travel around the country and always gain access to their health records, wherever they might be, because they'd all be in Middlesex. And every doctor and every hospital would have an online access to this building in Middlesex. And they would all use the same standard. And part of the standard is something called SNOMED, which is the systematized nomenclature for medicine. I imagine some of you are familiar with SNOMED. SNOMED was, it's now also being supported in a big way financially by the US, but the UK has supported it in a big way also. And they made a rule which was that every term which could ever appear in a health record in the United Kingdom had to be included in SNOMED, so that the health record would not need to have any free text. It would all be SNOMED codes. So there are terms in SNOMED such as injury due to crossbow accident. One problem with SNOMED, as we will see in a minute, is that it's run by a committee. The committee is now in Copenhagen, a multinational committee, which means that although it has many, many terms, it evolves rather slowly, where medicine is evolving rather quickly. And so SNOMED is well, we'll come back to it. So, magical thinking. But it was a disaster. So these are just some of the headlines. This is billions of dollars now, rather than just millions. One of the headlines, and the National Program for IT, Health IT, stunted the NHS IT market. It took all the money that there was for anything related to computers and invested it in just this one program. You weren't allowed to install Word on a hospital computer except through this program. And there were only certain companies which were allowed to get money from this program, which meant the costs of installing Word on a computer in a hospital went up several fold because there was no competition. They had a monopoly. So good they abolished it twice. The computer science community in England rebelled against it. So they said that the standards, the computational aspects of this were just nonsense and that they could not support it. But still, it was kept going and kept going. Now, one reason why it was a disaster was because people hated it. I mean, patients. Because they experienced, during the time when the program was being developed, rather embarrassing cases of doctors' laptops being stolen or left behind on trains containing huge amounts of patient data, or data relating to doctors' residency exams were stolen. And that turned out to be very controversial data. Now, these thefts were taking place in a time when people were being told that all their patient data would go to one building in Middlesex. And we assumed that the telephone lines into the building would never go down. They were afraid that somebody, WikiLeaks or somebody, would gain access to all of that data. And so there was a big movement called the opt-out movement. Newspapers would have full-page cut-out letters which they could fill out and send to their GP saying they wanted to opt out of the National Program for Health IT. The NHS executive was awarded the Big Brother Award for the most heinous government organization. And then again, they got the Big Brother Award for the most appalling project because of its plans to computerize patient records without putting in place adequate safeguards. Now, I don't know if we will have these problems in the US. They are building a national health information exchange. I don't know the degree to which that will be anonymized. But I do know that this is a problem. People need to like whatever we do, otherwise they will refuse to participate. So this is the big opt-out project. Now, the second reason for the disaster was well, I'm tempted to say Tony Blair. Tony Blair was a big fan of anything modern. And he was told that there were now modern, up-to-date computer standards for health information technology, HL7, SNOMED. And the people he appointed to build the NF, well, it's called Connecting to Health, that's easier. They believed that these standards were also in good shape. And so they thought, well, let's build it, use International Standards Organization accredited standards, and then nothing can go wrong. This was the idea. And things did go wrong, so it didn't work. They had a national system for booking appointments in hospitals called Choose and Book. So you could go with your computer with a few clicks and you could make an appointment. I think that in the whole life of the Connecting to Health program, they managed to make 64 appointments. And everyone hated it because there's a reason why appointments are scheduled in a rather non-computational way that they are scheduled. I'm sure that's true here too. So the standards didn't exist. HL7 is not a good standard. SNOMED is getting there, but HL7 is not showing positive signs. But the most important thing is that these big new technologies have never been tested. They were rolled out for $35 billion across the whole country before they had been tested. Now there is this strange paper published in a multidisciplinary journal of population health and health policy. Why national eHealth programs need dead philosophers. I don't think it's so important what they have to say here, but what they do say is that you should learn from other people's mistakes. So national eHealth programs unfold as they do, partly because no one fully understands what is going on. Now, I've talked only about electronic health records and meaningful use. That's here. Here we have really interesting medicine, genetics, molecular medicine, personalized medicine. So this I'm interested in. All of this has to be solved if you're going to make a national or even a regional health IT system work. And this is even without taking billing into account. So this was created for countries with single payers. So add billing to all of that, and everything which goes together with billing. So the UK program is an N of 1 case study. It failed. It was a disaster, a very, very expensive disaster. And these dead philosophers are regretting that people appear reluctant to learn from such studies. So this is my penultimate slide. We have a problem. EHR systems are developing too slowly. They are functionally outdated. They don't allow vital distinctions to be made, for instance, between disease and diagnosis. They confuse disease and diagnosis. They're run by large committees in Copenhagen, or by business managers, or by secret cabals, or by people who write government documents which are 133 pages too long. So in Buffalo, we are going to try and solve some of these problems. Again, just focusing on the tiny area in the middle where the electronic health record intersects with translational research. So what we're going to try and do is to work out what a good EHR system would be like and how we can fix the ones we have. And a good EHR system has to be easy to use, easy to train people to use. But it also has to generate data quickly, which can be useful for researchers. That is what we think. And so that's what we're going to try and do. I mean, we ontologists in Buffalo, I suppose I should have said. Okay, that's it.